Good afternoon, everyone, and thanks so much for joining us for our Leaders Initiative seminar series. Our speaker today is Dr. Amanda Leggett, who is an assistant professor in the Institute of Gerontology and Department of Psychology at Wayne State University, and an adjunct assistant professor in the Department of Psychiatry at the University of Michigan. Her research program focuses on the dementia caregiver stress process and mental health in late life. So with that, I will hand it off to Amanda.
Thank you so much, Courtney, and welcome everybody. It's great to see you all, and thanks for coming to hear about this kind of emerging work today. In a way, this is work that my team is really just kind of getting started on, so you're getting this presentation a little bit on the front end, and hopefully we can connect in the coming years as this work progresses a bit more. But today I will be sharing about who's on your team, exploring the variability in family caregiving networks for individuals living with dementia. So I got into this work really thinking about caregiving networks, family and friends who are involved in care provision. In my case, I tend to look at individuals living with dementia. But as I began sharing about this work with some of the caregivers in my research studies or individuals that I would meet, someone actually said to me, well, I would never call it my network. I would call it my team. And so that's kind of why I incorporated that in the title today. I totally relate to that. I think network is probably our scientific word that we think about it, but caregivers may not think about having a network at all. They may just think about having a team or really just having a family of different individuals who are supporting them. But I'll get a lot more into kind of how I'm thinking about this, how we might define this, etc., as we get into things today. So here's kind of my plan on what I'm hoping to share with you all. First, why do we care? Why would I be studying something relating to caregiving networks? So I hope to kind of build the case for you of why that this is an important topic, especially for individuals living with dementia. And then I'll go into thinking about kind of who's in a network. So individuals vary a lot. We know just as there's, just one individual with dementia, right? Each individual with dementia is experiencing their own disease, and there's a lot of variability among individuals. The same is true for family caregivers, and how they vary from one another is really important, especially as they may be partnering together in care provision. I'll talk about kind of how a network is defined, or what are different components that we think about that make up this network or this team. And then I'm going to go into, as I said, kind of some preliminary or emerging research that my team is getting invested in terms of how might we define these different types of caregiving networks, and how might those network types then be important as we think about key outcomes for both caregivers and individuals living with dementia. So first, why do we care about caregiving networks? So again, this is probably an opening slide that you are all quite familiar with, but we know that about 1 in 6 American adults, so an estimated 41.8 million individuals, is providing some form of unpaid care to a friend or family member aged 50 or older. So again, this is not dementia specific. This is broadly across a variety of diseases and disabilities, etc. But this is a substantial portion of our population. And then 1 in 2 of those caregivers, about 48%, is assisting a person living with a dementia. And as I said, these individuals tend to be enmeshed in families and groups of friends in these networks who are assisting someone with care. And yet this kind of de facto network or team, if you will, has really, over the past decades that caregiving research has really exploded, has been relatively neglected in the field of research. In contrast, however, networks is something that's been studied for quite some time. So some of you at the U of M are probably familiar with Toni Antonucci, one of our wonderful faculty at U of M. And she is really someone who began studying networks, but in terms of social relationships, so family and social relationships. And in the 80s, she developed this convoy model about how these social and familial networks tend to kind of follow us throughout the lifespan. And she really represented this with these concentric circles. So you could think of you as an individual having a network around you of friends and family that go with you throughout your life. And of course, this is multidimensional. Some people may enter your life and leave your life at various times throughout the lifespan. So this is really a developmental theory, thinking about how our networks change over time. And so she really visualized this as you in the center, and then you have people who you share your intimate aspects of your life with, kind of in that inner circle. And then we have a middle circle, outer circle. So people who may be part of your network, but less close in terms of that relational tie. And so her theory introduced this concept that our networks are multidimensional. We have a variety of relationships that really vary in terms of closeness, in terms of quality, and in terms of the structure of that network. And so individuals vary in terms of, how many individuals might be in these different circles and how these shift and change over the lifespan. So she was really one of the researchers to initiate this area of research, but again, from a more social and familial perspective. And then Laura Carstensen, another incredible researcher in the field of gerontology, she has somewhat of a complementary theory that many of you are likely familiar with, this socio-emotional selectivity theory. So maybe I'm aging myself by this slide. I don't know if any of the rest of you grew up on these Amelia Bedelia books, but I sure did. I think I learned how to read on these books as a child. And so in the Amelia Bedelia in a Surprise Shower, you may remember that she was helping to set up for a shower, a party that was happening, and she was told or instructed to prune the bushes, and she was sticking like figgy prunes in the bushes. But I like that as a representation because Carstensen's theory is really about how over time and with age, older adults become more selective and begin to prune their social networks. So she describes in this theory how in younger life, it's more advantageous for us, perhaps, to have this broad social network that really emphasizes knowledge-based goals. So what can we learn and what can we gain from having this kind of broad social network around us? But then she says this time starts to shift over time. And as we become closer and closer to our own mortality, we tend to emphasize more emotional goals. And one way to enhance that is by really only surrounding ourselves with people who are going to lead to our emotional well-being. As opposed to if we have that broader network, we might have people around us who might be minimizing well-being. So her theory suggests, over time, older adults began to kind of trim or prune those networks to really emphasize their own emotional well-being. So this has been studied quite extensively, again, kind of in social psychology settings. But then what about caregiving? So really, within the field of caregiving, the predominant model has been to study a single, or what we often call primary caregiver. So who is the individual that has the greatest responsibility of care for someone living with dementia? And typically we see this being either a spouse or an adult child, typically an adult daughter, for example. Yet clinically, if you talk to clinicians, or many of you on the call, you see coming into the clinic maybe a more diverse picture than just that. And we know also from prior research that there really tends to be multiple family members or friends, and increasingly paid helpers are in that mix, who are helping with a variety of aspects of care. And this is especially true when we think about diverse individuals with dementia. We know that Black and Latinx families, for example, they tend to be providing assistance for individuals with greater functional and cognitive impairment than do their white counterparts. And so really we see in our more diverse populations, larger networks providing care. And so dementia, I believe, is a really important, sample to think about networks, because dementia tends to have a longer trajectory of decline than many other chronic diseases, and it's associated with greater caregiving needs. So there's a greater need for more individuals perhaps to be involved in this care provision. So it's a really good sample to kind of think about this broader network. But the reality is that research has tended to focus on this single or primary caregiver, which has really kind of maybe been a superficial representation of what's actually happening in families as they're providing care. Also, when we look at some of the most common theories in this field, I believe that these theories tend to be a bit more individualistic, thinking about caregivers as individuals, for example, and they don't necessarily consider this dynamic interplay that in reality is happening between family networks. So we can think about theories like stress process models and role theories that really get into how an individual is perceiving the stresses that they're experiencing in caregiving and how they're perceiving their caregiving role, and then how that relates to outcomes such as their stress or caregiver burden, for example. And then we even have theories that actually get into how individuals enter a caregiving network. So we have the hierarchical compensatory model, and this model suggests that caregivers' status is a function of the closeness of the relationship. So again, as I said, we tend to see a spouse or an adult daughter, for example, as being typically the most common caregivers. And that may be a function of the closeness of that relationship, right? Your spouse or cohabitating partner is your most intimate relationship, maybe followed by an adult child. And so then this model suggests they would be the most likely ones to kind of step into that caregiving role. And then there's also this task-specific model of caregiver selection, which suggests that who becomes a caregiver really is dependent more on this match between what the care recipient actually needs and who's available to fill that role. So you could think about in a family, for example, maybe we might think from the compensatory model that an adult daughter might be the first caregiver based on that relationship closeness. But what if the daughter lives several states away and the son is living in the same town as the parent that needs that care? Then maybe the son would be most likely to serve in that caregiving role just based on his availability to meet specific needs. But again, these theories kind of get at who might be a caregiver or how that individual might be involved. But again, they don't think more broadly about all of the different members and what are the complex relationships within these given networks. So there has been some research, though, that has gotten at some of these components that do show associations between different facets of a caregiving network and really critical outcomes that we like to study in caregiving populations relating to health and well-being. So again, I'm hoping to convince you of why we believe this is a really important concept. So first, research has actually looked at skilled nursing admission. So which individuals are most likely to be admitted into skilled nursing care. And this one study, recent study, found that if you had a significant other, so a spouse or again, cohabitating partner as a caregiver, you actually had reduced hazard of being admitted into that skilled nursing facility. In contrast, the same study found that having a caregiver in your network who was actually helping you with medical caregiving tasks, then you had an increased hazard of admission to that skilled nursing facility. Other research has actually looked to see, who is receiving more hours of care. And individuals tend to receive more care, greater intensity of care based on hours if they have more individuals in their caregiving network, if they have more family members in that network, if they have more females in the network, and kind of relating to the theory I was describing on the prior slide, if they have network members who live in closer proximity to them, they're more likely to receive more hours of care. So you can begin to see kind of how this network can influence the care provision for individuals. And then lastly, another recent study actually found that having a larger caregiving network with more members in it was actually associated with more anxiety and depressive symptoms in the care recipient. So while that larger network could potentially be better for the caregiver in terms of having more individuals to delegate responsibilities or tasks to, this study found it could potentially be worse for the care recipient. And these complexities, really kind of what's better for a care recipient versus a caregiver, are just beginning to be understood, and what I'm really hoping to dive into more in this line of research that I'm involved in. So again, most of the field focusing on this single primary caregiver, which is really an artificial way to think about caregiving. As we know, most individuals do have multiple individuals in that network providing care. So I'm really interested in exploring more who is in the network. How are these individuals in networks varying from one another in terms of their approaches to care, and how can this impact outcomes? And then also, how does this, influence both the caregiver, but also the individual with dementia? Because if we can identify maybe caregivers with problematic approaches or networks that aren't functioning well in terms of best outcomes for both parties, we can start to better tailor, target, individualize our approaches in working with caregivers and working with broader networks to improve these caregiving outcomes. So again, moving from thinking about just the one primary caregiver to all individuals who are involved, so we can really better understand how to work with these networks. So some of you who've been around the MADRC for a while have probably, perhaps, heard me talk about this next section. So it may be a review for some of you, but new for others. So next I want to talk about research that stemmed from my K Award that I did actually when I was on faculty at University of Michigan, which we call caregiving styles. So some of you may be familiar with the concept, the psychological concept and research of parenting styles, right? We know, even if you've never been a caregiver, you've either been a parent or had a parent, right? And we know that parents vary in terms of how they discipline and show love and how responsive they are to their children in their parenting practices. And so not to equate caregivers in the same way necessarily as parents. I do not mean to necessarily draw that similarity, but just to say that in a similar way, not all caregivers are alike, and yet they're often kind of grouped into this one-size-fits-all bucket. So the goal of my K Award and that research was to really kind of dig in a mixed method study to better understand, what are the distinct ways, both cognitively, that caregivers are thinking about their approaches to care, and then behaviorally, what are they actually doing as they engage with the individual with dementia and encounter challenges in their daily lives. And from this, we were able to identify 5 distinct, what we call caregiving styles, or you could think of them as profiles or clusters, even, if you will. So 5 distinct caregiving styles that really varied from one another, each style, in terms of their cognitive behavioral approaches to care. But then within each style, they held a lot of similarities. So again, because this may be review for some of you who've been around the center for a while, I won't dwell a ton here, but I do want to give you kind of an overview of just the variability we see in these caregiving approaches. So our first style we call the Externalizer. This was based on a sample of 100 from my K Award study, mixed method study. So when you see N equals 14, that's just to say that out of the 100, 14% of caregivers fell into this style that we call the Externalizer. Now, the key characteristic quote for this group is them saying, I'll say, if you think you're punishing me, you're only punishing yourself. So externalizers cognitively had a very superficial understanding of dementia. So they knew that their relative or friend had a diagnosis of a dementia, but they did not understand that many of the symptoms that this individual was displaying were a result of a progressive disease. So they viewed them as intentional or targeted towards the caregiver as trying to get on that caregiver's nerves, for example, as opposed to something that was a symptom of a disease. They approached care in a very rigid way, kind of only could think about one way to handle things. In their interviews that we did with them, they talked a lot about how stressful this caregiving process was for them, without really putting much reflection into how the same scenarios could also be stressful for that individual with dementia. Behaviorally, we see them responding a lot with helplessness, frustration. They would respond sometimes with anger. Sometimes this could be yelling or placing blame on the individual with dementia when a challenging scenario arose. And then something interesting we saw with this group is as an individual with dementia maybe was hallucinating or having delusions or kind of experiencing a separate reality within their disease. The caregivers that were externalizers were really trying to reel them back in. That's that fishing pole there, trying to bring them back into the caregiver's own reality and not really understanding how they could be in a different reality, if you will. So take, for example, one of our caregivers whose wife was out at the restaurant and, telling things to the waitress that had never happened, were completely untrue. And this caregiver was mortified, and he kept telling the individual with dementia, why are you lying? Why are you saying this? This never happened. And so just not fully able to grapple with the fact that this reality has shifted for this individual. Next, we have the group we call the Individualist. Their characteristic quote is, you just live through it, you just do it. This group takes a very direct kind of point A to point B approach in their caregiving, more emotionally removed. So they're not really bringing emotions into it in the same way our externalizers were. They just talk about, I take care of things, if this goes wrong, I handle it. I just do it, if you will. Behaviorally, the most common approach we saw this group utilizing was more preventative management strategies. So if something went wrong, they were just trying to do something to prevent that from going wrong again in the future. And we saw them really navigating pretty well without seeming to experience a ton of caregiving challenges. So even though they were a little bit of a lone wolf, kind of placing everything on their own shoulders, they were navigating it okay. The concern is, as difficulties arise, as the disease progresses, will they hit a wall with that approach no longer working for them? And we have our learner style. This was our largest group. And their characteristic quote is, so as you go along, you stumble on a few things, but stumble it is. And this is a group that's kind of in the middle of the spectrum, if you will, really trying so hard to address the caregiving challenges that they were confronted with, but really expressing in their interviews this feeling of being stuck, that we're trialing and erroring, we're trying to do whatever we can to address these caregiving challenges, but it just doesn't seem to be working for us. And so they were trying a bunch of strategies kind of on the spectrum of more maladaptive strategies to more adaptive care practices. But what really set them apart was the fact that no matter what they tried, it wasn't resolving the caregiving difficulties that they were experiencing. But kind of in contrast from that externalizer and that individualist, they really recognized that their approach wasn't working for them, that they needed to make some changes. And emotionally, they kind of span the gamut across the board. So our team was really excited about this group as a group of caregivers that might really thrive in the behavioral interventions that people are building and developing to kind of help caregivers navigate caregiving better. This is a group that we believe would really succeed there, whereas an externalizer or individualist might just not be at the point where behavioral intervention would be the best fit for them. Next, we have the adapter. This group always expects the unexpected. So this group, again, kind of similar to individualists, wasn't bringing a lot of emotions into their interviews with us. They really were focusing on this huge cornucopia or toolkit, if you will, of different caregiving strategies that they had at their disposal that would work for them. So in contrast to the learner who's trialing and erroring, the adapter really felt some mastery over their strategies that they were utilizing that were effective for them in navigating caregiving challenges. And they talked a lot about how this was a process. They learned this over time. So maybe earlier on in their time of being a caregiver, they didn't know what to do, but as they've gone on, they've really learned and been able to navigate caregiving more effectively using both positive and more negative, if you will, caregiving strategies. But we saw that this group on average had been providing care for about 7 years. So our interest is in how can we get someone to be an adapter with this huge toolkit at their disposal without 7 elapsed years of caregiving, one of our interests. And then finally, we have what we call the nurturer style. Their quote is, I value making the most of what is present rather than what is lost. So this group probably contrasts most perhaps with the first group, the externalizer. So whereas the externalizer was talking about how stressful caregiving situations were for them, the nurturer was really sharing with us in their interviews how stressful this situation must be for the individual living with dementia. I apologize, that's what the PLWD acronym is here, person living with dementia. They viewed caregiving with a lot of positive affect, kind of natural efficacy. So they viewed themselves as more natural caregivers. A couple of our caregivers in this groups were nurses, for example. So people who are drawn to caregiving kind of more naturally, if you will. They use strategies of comfort, working as a team with the individual with dementia to accomplish caregiving tasks. And in contrast, again, with that externalizer who's trying to reel that individual with dementia back in to the current reality, nurturers were willing to dive right into whatever that reality was. So I've shared this story a lot, but one of my favorite examples of this was a wife whose husband was having hallucinations of men coming into their home wearing black coats and black hats. And he would be very concerned about this, these men entering their home. So rather than saying, what are you talking about? There are no men, in our home. This caregiver would talk directly to the men. She would open the door. She would try to shoo them out to try and comfort her husband. So in a sense, interacting with this reality that wasn't actually there. So one of the reasons we believe this is very important is we actually do see associations with a variety of caregiving outcomes. I'm just highlighting a very few here on this slide. And this is based on regressions where we used externalizers as our reference group. So the other styles are being compared relative to the externalizer style here in the regressions. In particular, the nurturer style showed very positive outcomes relative to the externalizer group. So you can see that they reported that the individual with dementia within their care had significantly better quality of life. They reported less distress in managing behavioral and psychological symptoms. They reported less distress in managing functional impairments, such as activities of daily living. And they even had lower levels of cortisol in terms of the area under the curve, which is a reflection of the overall output across the day of cortisol, which is a commonly measured stress hormone. So relative to this externalizer style, we weren't seeing as much reactivity, both kind of psychologically and even physiologically. Also, the learners and adapters reported less behavioral and psychological symptom distress than that externalizer style. And these regressions, you can see they adjusted for a variety of demographic and care context characteristics. So we do see variability in outcomes across these different styles that do suggest that the way we think and approach care differently does impact our own outcomes as a caregiver. I couldn't let this moment go by without putting in a little plug that we are currently taking this research to the next step. We are developing a measure that a caregiver or a clinician or a researcher could utilize to really get at someone's caregiving style in about a 20-item measure, as opposed to having to run machine learning models or qualitative analysis, as we did in my K Award study. So a quick and dirty way to really identify at this moment in time what is someone's caregiving style, so that we could think about better targeting and tailoring our approaches. So all this to say, I just had to throw this slide in there that we are currently recruiting caregivers for this study. It's an online survey. We've developed a bunch of items that we're testing out so that we can identify the best items to really capture these concepts in our caregivers. Happy to chat more at the end if people have questions about that. But let's move into the piece on networks. So I want to get into now kind of how the field of research currently is thinking about defining these caregiving networks. So I pulled a variety of different papers here, and they tend to look at some kind of common characteristics that make up these caregiving networks. And I'll be using these characteristics in some of the results that I'm presenting today. So first, we have membership. So who's in the network? Do you have a spouse in the network? Do you have a child? Do you have a friend? Or do you have a niece or nephew, etc.? We tend to think about the size of the network. So how many individuals are part of this caregiving network? Is it large? Is it small? We think about the tasks. So what are the tasks that network members are assisting with or involved in terms of caregiving? So are these network members helping with medical tasks, for example, managing someone's medications? Are they helping with laundry? Are they helping with bathing? A variety of these tasks that over a course of a dementia, individuals may need assistance with. And then in addition to what tasks are being done, are people sharing? So are individuals taking ownership for one task, for example, within the network, or are multiple individuals helping out with similar tasks? We can also think about intensity. So in terms of hours of care, how many hours of care is that individual receiving from their network? And then we can also think about kind of the division of care. So how is this network dividing and conquering or delegating these responsibilities? So I'm using these words generalist and specialist, which is based on Brenda Spillman's work, who I've cited here on the slide. She can have developed this concept. But we can think of a generalist as someone who's helping with a variety of different caregiving task domains. So maybe helping with both medical tasks and household tasks. Whereas a specialist is someone who's helping really with one type of caregiving domain. So maybe a specialist is a neighbor who the main way that they help is they drive their neighbor to doctor's appointments, for example. So all they're helping with is transportation. So before I get into kind of some current findings that we have been working on in our team, I just want to give you like a very brief overview of the data that I'm going to be talking about here. And this data is the National Health and Aging Trend Study. We tend to refer to it by its acronym NHATS. And if you're not familiar with the data, it's a nationally representative annual panel study of Medicare beneficiaries. So adults age 65 or older living in the United States. So it is nationally representative. And a nice advantage of this data is it can be linked with Medicare claims, which I'll be talking a little bit about. And although NHATS is not a study that's focused on a dementia population specifically, it does have measures to get at probable dementia status. So just in brief, and again, I'd be happy to share more about this at the end today. We capture in NHATS this probable dementia status based on whether a diagnosis of dementia has been reported, a score on this 88 dementia screening interview, or whether they score above or below 1.5 standard deviations below the mean, on 2 domains of this 88 test. So memory, executive function, orientation. And they were able to achieve good sensitivity and specificity, kind of validating this measure against the ADAMS study. If any of you on the call are familiar, the ADAMS is part of the Health and Retirement Study, which actually utilized 3 to 4 hour structured in-person assessment and a clinical consensus diagnosis. So this, even though it's not a clinical diagnosis, it is assessed kind of in comparison with this ADAMS study measure of dementia. And then how does NHATS really define caregivers? So this study of Medicare beneficiaries, these individuals are asked if a family member or unpaid non-family helper provides them with any assistance on functional care tasks. And if so, that participant gives the names of individuals, all individuals who help with those tasks. So from this, we can kind of capture this whole pool of individuals who are providing functional assistance to an individual that has a probable dementia. Now, sometimes this is a proxy in cases where the individual with dementia is not able to do the interview themselves, then a proxy is stepping in and kind of doing this on their behalf. Okay, so specifically some results I'm going to share with you quickly today. We draw from the 2017 wave of this NHATS study. And I'll be presenting data on 336 community dwelling individuals with probable dementia. In other words, we'll be looking at 336 caregiving networks. And these networks had 971 helpers or caregivers who were either a family member or unpaid non-family member, again, helping with functional caregiving tasks. And I'm going to share with you some characteristics, just like I previously described on the prior slide. So I won't go into great detail here because I'm going to share a little bit about clusters from a latent class analysis. These measures have been dichotomized for ease of interpretation. So our network size is dichotomized as either having 2 members or 3 or more members. Then we have who's in the network. Do you have a spouse, a daughter, immediate family, non-immediate family, any non-family in the network? Do you have individuals sharing 2 or more network members helping with these task domains? And then again, this generalist and specialist concept we capture. So getting into the good part, here, and I want to make sure I leave time for discussion at the end. So in this sample that we have in 2017, kind of who is in the network, or what does this network look like? So you can see about 50% of the individuals with dementia had only 2 members in their network, and the other 50% had 3 or more. So the mean being about 2.9, but you can see the range is quite large. So we had between 2 and 9 network members in these networks. You can see actually not so many had a spouse in their network, just above 20%, whereas the majority of networks included an adult daughter, so more than 60%. In terms of non-immediate family, about 40% of the sample had a non-immediate family member in the network. This could be like a niece, a grandchild, a sibling, for example. And then here you can see more than 90% had an immediate family member. So a spouse, an adult child. We also classified daughter-in-law and son-in-law in this category. So because of that, we're not going to take this variable into the cluster analysis that I'll be describing in just a minute, because there was very low variability, very low cell size in terms of individuals who didn't have an immediate family member in their network. And then almost 20% of the networks included a non-family member. So again, these are unpaid individuals. So family, family friends, for example, neighbors who are in the network. And then in terms of generalists and specialists, again, you see basically every single network had a generalist, meaning someone in the network who was helping with multiple task domains. So again, this variable is going to be left out in just a minute in our cluster analysis because it was pretty universal across the networks. Everybody had a generalist. And then you could see about 2/3 of the networks had a specialist. So somebody who is in that network who was only assisting with one task domain. And then in terms of the tasks that were being shared within the network, you can see about 40% of the network had 2 or more individuals who were helping with medical tasks. But actually 8.9% of networks didn't have any helper providing medical tasks help. And you can see between 0 and 5 helpers helping with medical tasks. A lot more sharing going on with household tasks. Of course, individuals with dementia need more assistance with these kind of across the stages of disease. So you can see only one caregiving network did not have any member providing household task assistance. And you can see between 0 and 9 helpers assisting with household tasks. Mobility tasks, about 50-50. So about 50% of the networks had 2 or more individuals assisting with mobility or self-care tasks. And then finally, again, about 50-50. So about 50% of networks had 2 or more individuals who were assisting with transportation. So driving or taking the individual with dementia to an appointment or to the grocery store or something like this. But you can see no network had more than 2 individuals helping with transportation. So networks had a lot more involvement in terms of mobility and household task assistance. Okay, so what I'm going to get into now is how we are starting to kind of similar in our approach to my caregiving styles work, thinking about how we classify kind of profiles or common types of caregiving networks. And so we have done this with a latent class analysis. So this is a type of cluster analysis that groups these networks based on common responses on these items or indicator variables that I've just described. And so through this analysis, we look at AIC, BIC to get at kind of goodness of fit statistically. And then we also look theoretically to see what makes logical sense in terms of the literature. And based on both of those steps, we identified the best fit was really a 3 cluster or 3 type model. So I want to share with you kind of what we identified here. So as you can see along the x-axis, these are all of these indicator variables that we put into this latent class analysis. And then on the y-axis, what you see is probability. So a 1 would mean that it was like a universal likelihood that someone has a large network size in that sharers group, or a high, almost perfect probability. And then the 0 would be no chance that somebody had that was in that particular cluster had a large network size. So let's just take the sharers, for example, and these are just names that we've derived to kind of represent what we're seeing here. So if you look at the gray bar, you can see that our sharer network style or type had a larger network size, so 3 or more caregivers in the network. Moderately likely in the middle there in terms of having a spouse. They were more likely to have a daughter in the network, highly likely to have a non-immediate family relative to the other cluster types in the network. And then again, as far as the clusters go, pretty likely to have a non-family member in the network. So these are pretty complex networks here. Not as likely as the blue line, as you'll see in a minute, to have a specialist in the network, but still pretty likely to have a specialist. And again, if you recall, every network had a generalist included. And then why we call this group the sharers is you can see that across the board, this was the particular network profile that was most likely to be sharing caregiving tasks within the network. Then if you want to look at the orange line, we call this group the small but mighty. So again, this network tended to have just 2 members in it, less likely to have a spouse in the network, but more likely to have a daughter, low likelihood of a non-immediate family member or non-family member, and very low likelihood of being a specialist. But you still see pretty high levels of sharing here. So we call this group small but mighty because even though it was a smaller network with kind of less diversity in its membership, those few members of the network were doing a lot of sharing. So they're responsible for a lot, if you will. So they're small but mighty. And then finally, if you look at the blue line, we have what we're calling the specialist group. So again, more likely to be a smaller network, higher likelihood of having a spouse, a little bit lower likelihood of a daughter, and non-immediate family. But what you see is basically universal likelihood that they have a specialist in their network. And as you can see, they were significantly less likely than our other profile types to be sharing tasks. So having multiple members in the network, doing the same task. So they were much more likely kind of specialize, and each individual in that network is going about their own task provision. So kind of to describe these a little bit more, almost half of our networks fell into that sharers group. 23% of our networks were small but mighty, and about 1 in 3 of the networks were specialists. We did look to see if these network profiles differed from one another in terms of some demographic characteristics. Now, these are demographic characteristics of the individual living with dementia who has this network around them. So we didn't actually see the networks differed significantly by age. Gender was marginal, where women were marginally more likely to be in that sharers network, which does align with prior research, which suggests that women tend to have broader social networks. So it aligns that they might be more likely to have, a larger network that's sharing in terms of their care provision. But again, this was just marginal. And of interest, there was no significant difference between these network types in terms of the number of chronic medical conditions that they had outside of the probable dementia. So it's not a difference that we're seeing based on kind of need per se in terms of multimorbidity. That being said, we did see a significant difference by race. So the number of white individuals and the number of other race, we classified race as white, Black, and other. So in this analysis based on sample size, so there was a pretty similar proportion of whites and other races across these 3 networks, but we did see a pretty big difference based on Black individuals with dementia. So Black individuals with dementia, over 60% of them had this larger sharing network, and they were much less likely to be in a smaller specialist network. So this kind of aligns with what I was prefacing early on, that especially for individuals with dementia or Black individuals with dementia, we do tend to see more individuals in the family engaged. And you can see they're engaged in such a way where they're really interacting and sharing tasks. Okay, so to kind of wrap up, I do want to share some emerging findings that we're seeing in terms of how these networks might be important in terms of how they relate to outcomes for caregivers and for individuals with dementia. So I do, again, want to preface, this is kind of hot off the press. It's emerging. So please keep that in mind. We are still kind of working on these analyses. And so your feedback certainly appreciated. But we did look at differences in these three types of networks in terms of some caregiving well-being outcomes. So these are ANOVAs here, and you can see we did find significant difference in terms of emotional difficulty of caregiving, kind of in a similar burden sort of measure that is captured within NHATS and NSOP. So what we see here is a higher mean here indicates more emotional difficulty. And so what we're seeing here is that the small but mighty group tended to have a more elevated mean emotional burden score relative to that specialist and share network. So those smaller networks that were really involved in a lot seem to perhaps have a higher mean of emotional burden. This next finding, again, with caution, it's marginal, but you can see the p.06, so almost reached significance. Again, we see the small but mighty network had maybe marginally higher caregiving overload, kind of overwhelm relative to these other two networks. And then finally, we also looked at the social support that these networks were receiving. And here we see that caregivers in that specialist network, so a smaller network that's not engaged in as much task sharing, were less likely to receive social support from others than their counterparts in the share or small but mighty group. We also included this one in a regression where we're adjusting for demographic characteristics, and this finding maintains in the regression. The other two variables were significant in the ANOVA, but not once we accounted for these demographic characteristics. So it does seem that both the sharers group and the small but mighty group, based on this regression, received significantly more social support than the specialists. So kind of what do we take away from this? These small but mighty networks were carrying really complex caregiving responsibilities on their shoulders with limited others in the network to maybe delegate to, which may relate to the emotional experience of caregiving that they're experiencing. Our specialists were really only helping with one type of caregiving task. So maybe they needed less social support from other friends and family, but they were receiving less than their counterparts. I think what will be important as we progress this work forward is kind of how these networks adapt with changing care needs that come over time with the dementia. All right, I'm going to go quickly here as I'm keeping an eye on the time. And I want to wrap up by just sharing a little bit that we also have looked at with this data in terms of a health services outcome, which really has a lot of impact for individuals with dementia. We know individuals with dementia have higher rates of potentially inappropriate emergency department utilization. And these emergency department visits carry a lot of risks for individuals with dementia. So it's a really important outcome in terms of health services. And what's, I think, unique about emergency department visits is caregivers are often the decision makers around whether the individual with dementia does go to an emergency room, for example, whereas the doctor is going to be the one who's going to more have decision-making power on whether that individual in the emergency department then is admitted into the inpatient care in a hospital, for example. And prior research by my team and others has actually found that caregiving stress, depressive symptoms, fatigue, so caregiving outcomes actually predict individuals with dementia emergency department visits. And so we want to also think about how a network might influence this. So here we're using 2015 NHATS data with linked Medicare claims from fee-for-service Medicare coverage. And we are doing a binary outcome of whether or not someone had a past year emergency department visit. You can see half of the individuals with dementia in our sample did have that emergency department visit. And just some brief demographics here. I'm going to kind of breeze through these for time, but you can see individuals who lived in urban areas more likely to have an emergency department visit, individuals with higher self-care needs, more likely individuals with larger caregiving networks, more likely to have an emergency department visit, and individuals who had multiple network members involved in mobility care provision, more likely to have an emergency department visit. But And kind of narrowing in here on our logistic regression results, you can see some of these characteristics that we've been looking at and how they predicted emergency department visit. So what we really see here is the more complex characteristics of caregiving networks were predicting an emergency department visit in the individuals with dementia, adjusting for a variety of characteristics, including self-care difficulties and chronic medical conditions. So individuals who had non-immediate family members in their network, had a larger network, had networks that were involved in sharing of mobility and self-care tasks, had more specialists, more generalists in the network, more likely to have an emergency department visit. And now you might say to me, well, Amanda, these are probably individuals with greater care needs, which I 100% agree and acknowledge. That's very likely. And in fact, individuals with more mobility care provision, they may be at greater risk for falls, for example, which is a common reason that individuals with dementia might end up in emergency department visit. So definitely acknowledging that. However, even accounting for self-care needs and multimorbidity within our regression models, we still see these complex care network characteristics increasing risk for this emergency department visit. So I think there's still something to say here about the influence that these complex networks could have on health services utilization. And existing models that try and predict health services utilization don't tend to incorporate factors around networks of care. So all this to say, I think as our field progresses, my hope is that we start to, consider these broader networks and how they fit into our more individualistic theories that we often use to guide our research that we're looking at when we're predicting outcomes for individuals with dementia and caregivers. So I know I want to leave some time for discussion. So I will just wrap up here by saying we believe individuals vary in how they provide care. That's my work in terms of caregiving styles, how they think about the caregiving role. And then also our research is starting to show that networks look and function differently. And this variability, I believe, is really key in understanding caregiving outcomes. So we want to start thinking about if an externalizer, a nurturer, an individualist walk into a bar or are part of the same caregiving network, how is that influencing outcomes? We want to think about who's in this network, how are they providing care, and how does this relate to important outcomes, which I hope will help us in better assisting individuals with dementia and caregivers and moving forward. So with that, I'd like to say thank you, acknowledge my incredible collaborators and research team has been involved in this work over the years, and my funding from the National Institute of Aging, the wonderful Michigan Alzheimer's Disease Research Center included. So thank you so much, and hopefully I've left at least a few minutes for us to have some discussion here. So please jump in, or if there's questions in the chat, hopefully Courtney and Stephanie can help me out with that.
Hi, Amanda. Great presentation, like
Thank
always.
you, Irving.
One question I have about the size of the network versus those in the network engaged in providing assistance. Using the enhance, we found that the size of the network, for example, for Latino was the biggest one, but actually those in the network engaged in providing help was the smallest.
Oh, interesting.
So
okay.
one aspect of the network is the size, but one is how many of those in the network are really engaged in providing the care. I don't know, something that I want to bring to your attention that we found when we use the NHAT.
Definitely. Yeah, no, it's really helpful to hear. And actually, I have a new postdoc. I don't know if she's on the call today, just joining my team that's interested in kind of capturing some of these racial ethnic differences. So something we want to explore more. So that's helpful to hear. That even these large networks, what actually each individual member is doing could be smaller, and capturing. Yeah, we'll have to think about how we capture that better in our models.
We published that part of the SDI for the MACFAT, so you can take a look at that.
Okay.
Another point is that Rich developed in a paper that we are working on, like a three-dimensional kind of way to look at outcome.
Okay.
So you wanna talk to him about it. So
Yeah,
looking
I
at
will.
in a three-dimensional way to look at variables that are affecting outcome. And
Hmm.
it's kind of cool how those you can have more than one fact, you can have three factors interacting in that
Mm-hmm.
dimensional regression model, if you will.
Oh,
You
cool.
will be able to explain it better. I vaguely understand, but it's really cool because you can see how these variables interact to predict an outcome.
Yeah, awesome. He's a co-I on this grant,
Yeah.
actually. So yeah, I will for sure have that conversation with him. Thank you.
Right. Good.
I think I see Florence with your hand up.
Hi, Amanda.
Hi.
Great presentation. I want to know how you're going to recruit those 200 caregivers. But we'll
Okay.
talk about that.
Yeah, we'll talk
Um,
about that.
Quick question. Did you take into account ethnic enclaves and how that affects these different pockets of caregivers that you've identified?
Yeah, not yet. I think part of the problem is cell size. So NHATS has particular requirements around like the number of people. You can't go below a certain number in particular cell sizes. And the way we restricted our sample, we were a little nervous to do that initially, but I'm hoping to do more of that type of work in moving forward. We're just going to have to think about how we might, combine different waves or think creatively about how we might get a larger sample to be able to explore some of those things. Cause I would really like to do that. But as of yet, we haven't gotten there.
Thank
Yeah. Robin. Hi, Robin. I see your hand up.
Hello.
Oh, hi, friend.
Hello there. Great presentation.
Thank you.
I had a question about the outcomes.
Mm-hmm.
And so could you say a little bit more about the outcomes that you're measuring from the perspective of the person living with dementia, and if there are any outcomes that you wished you could measure or want to measure in the future?
Yeah, great question. So, in what I've described, at least on the second half of this, on this networks piece, is that what you're asking about, or are you thinking more about the caregiving styles piece?
The networks piece.
Networks. Yeah. So with the networks, we're, limited to what's available in the in HATS and NSOC. So I think I failed to mention that our caregiving outcomes that we did look at were coming from the National Study of Caregiving, which is associated with the NHAT study. So that overload, emotional difficulty, we looked at social support. I didn't put it on the slides. We did look at a couple of other measures. We looked at caregiving gains, but didn't see any significant differences there. If my analyst is on the call, she might help me remember, because I think there was something else too that we looked at that I'm forgetting. So we are limited to what is available there. We are hoping to, over the course of this project, look at more individual with dementia outcomes. So from NHATS, we can get at some variables on their mental health. And then we are linking with Medicare claims. So we're hoping to look at different healthcare outcomes that a caregiver might have influence on, whether or not the individual with dementia receives that health service, as opposed to, just things that are medically necessary. We're going to try and account for some of that. So that's kind of what we're thinking about currently. I would love to have my caregiving style piece in some of this too, but it's not, it's not there in this nationally representative data to kind of think about that variability too. I'm always interested in kind of the biopsychosocial stuff. So I'd love down the line to think a little bit more about, health impact, physiological impact. So those are all things we're thinking about, but in terms of things that we can currently look at, it's kind of limited to the measures that we have available to us in these data sets, which the beauty of these secondary data sets is that we have this nationally representative sample, large sample size. We have a pretty large breadth of measures, but we don't have like long in-depth measures in these national surveys. So hopefully this is the first step. In future work, we can kind of dive into further outcomes.
Thank you.
Yeah. Thanks for the questions.
It looks
Oh,
like
Huazhang.
yep.
Yeah, I see.
Yeah, I'm sorry. It's I know it's 1 o'clock, so I try to be quick. And thank you so
Sure.
much for excellent presentation. I was just wondering whether using the enhanced answer we can look at maybe in future, but I don't know whether it's already available to look at actually dynamics and network change over, for example, as the dementia progresses. Whether style and the other characteristics of network changes. I think that would be very interesting.
That's definitely
Yes.
my hope, Huazhang. So we'll talk more about it. Yeah, I'm definitely hoping to be able to do that. And that's a nice thing about having the longitudinal data is that hopefully we can follow some of these networks over time and see some of those dynamics. So yes, that's definitely a goal of the work. And we will collaborate more on that.
Thank you.
Yeah.
All right. I think that is it for today. Thank you so much, Amanda, for your talk. And I will get this up on YouTube and I'll share the video link with everybody. And
Sounds
please
great.
please fill out the evaluation if you haven't. We definitely appreciate everyone's feedback.
Yeah. And reach out with any questions if I didn't get to answer.